Hi everyone from MedStream 360. My name is Dimitri Siqueira,
Verifica o
and I'm
microfone
proud to be
rosa,
here with
por favor.
my colleagues to show you
O
the
microfone
first case
rosa.
for today. Here on my left, Alberto Servoni, who's going to be
Exatamente, só o
the
rosa.
first operator of this case, and Michele Birchi, our fellow in structural heart disease intervention. We have a team here from echo and from anesthesia. And without further ado, I would like to show to you the case that we have for today. May I have the first slide, please? So this is a 75-year-old gentleman, non-frail, independent. As past medical history, he has hypertension, and he presented to our hospital with symptoms of heart failure, dyspnea class 2. On surgical risk assessment, the Euro score 2 is 1.1, and the STS score is also 1.1. So a low-risk patient for surgery. Lab tests are pretty unremarkable, except for the renal function is mildly reduced, 59, the GFR. His ECG, you can see here, he is on sinus rhythm with signs of pressure overload and a poor R-wave progression on the precordial leads. These are the echo findings. He has a preserved left ventricular function with EF estimated on 65%, mild mitral regurgitation. The mean gradient across the aortic valve is 66 millimeters per mercury, and the estimated aortic valve area is 0.6 square centimeters. This is a CT workup, and you can appreciate that this patient has a bicuspid, very calcified aortic valve. The annulus is eccentric, like we usually see on bicuspid valves. Diameters are 22 per 27. The area of the annulus is 470 square millimeters. He has no ascending aorta dilation. You can see here the measurements. The coronary height to the annulus are good, both on the left and the right. They are above 12 millimeters, so this patient has a low risk for coronary occlusion during the procedure. And here we can appreciate, we can categorize the type that bicuspid that this patient has. He has a bicuspid type 1 aortic valve with a raphe between the right and the left cusp. And in terms of sizing, you can appreciate on the left-hand side of the screen the intercommissural distance 4 millimeters above the annulus is 29 millimeters. And we also simulate two different sizes of valve using the Trimential software. And we simulated 24.5 millimeters and also 26 millimeters THV. And we decided here to implant 26 millimeters valve. This is the suggested coplanar view, LAO 22 caudal 7, you can appreciate here that the valve is pretty horizontal with an aortic angle of 60. And here, Fausto, we perform a CT reconstruction of the axis, the femoral and iliacs, and you can see that this patient has diffuse disease and with small diameters below 5.5 with some calcification. So I think that this is our major concern related to this case in terms of TAVR. So
Do you think that could be a contraindication
I think that we are pushing the limits here because the diameters are below 5.5. But we are going to protect the vessel that will receive the sheath, the large bore sheath, and we are to deal with difficulties or complications that could happen on this case. So in summary, 75-year-old gentleman, non-frail, severe symptomatic aortic stenosis, low surgical risk score, and as anatomical challenges for this case, we can point it out bicuspid aortic valve, horizontal aorta, and small diameters of the femorals.
So this patient, if you would have done the partner trial, low risk, at this time, this patient would be easily included in the trial.
I don't think so because maybe we have two exclusion criteria for the low risk trials, mainly bicuspid.
Oh, okay.
And also the small caliper of the femorals.
So we are going ahead to the indication for this.
But we discussed this case during our heart team meetings, and as you can see, we selected this patient for TAVR, and we're gonna show you.
Okay, good. What have you done so far?
So maybe Alberto could
okay, Alberto, what have you done?
Hello,
please?
everyone. So,
could you please bring the camera to the femoral artery now? Thank you.
So first, we made the ultrasound guided puncture in the right femoral for the large bore access. The contralateral access in the left femoral, we puncture using ultrasound as well, and we use to protect with a 0.018 wire to lead with a complication if we have. So if you can see in the angiography, we have here the 0.18 wire protecting, and we have already placed the sheath, the 14 French sheath. So I think we can show the first angiography we have performed.
Just after puncture, right?
Yeah.
And then we did our first angio here. We have a coplanar view with the three cusps at the same plane.
Did
you can also appreciate how calcified this valve was.
So this is going to be a minimalist approach again.
Yep.
And have you got some echo images at this time?
Yes, we can show you
Yeah.
some images from echo.
Yeah. Hello, everyone. We have here some images from pre-procedure, and this patient somehow yesterday we estimated the median gradient in 66. Today we got to see that it's 124 for 88. Yeah, the median is 88. It's an aortic valve extremely calcified. It's even hard to see the flux through the valve, through the native valve. And we also re-estimated the area. It's 0.7, 0.6.
Okay, thank you, Wendy. So, what are you, Alberto is trying to cross the valve now?
using an AL1 and the straight tip wire, we are trying to cross the valve.
Do you usually use the echo images to help you?
No, to cross the valve, usually we don't use the echo images.
But after you cross the valve with the guide wire?
Of course. To place the stiff wire in the interior in the left ventricle, we usually use the
echo
image of
image.
the echo to help us to place the wire in the apex of the...
So Alberto just crossed the valve with a straight wire, and then we move to another projection to area O. Just to
It's
see.
very, very important teaching because the complication can start right here.
That's it.
So if you use the echo just to see where you are with your guide wire, it's going to be really helpful. And change all the views that you have here, the projections. Sobe para mim aqui, por favor.
So we're gonna exchange the wires here, and we're gonna put a long J wire.
Okay.
Just to put the pigtail into the left ventricle.
Again, as you have mentioned to you, and we have trying to tell you during all cases that we have done, there are some rules that we need to follow. We cannot abbreviate the procedure. So now you have another wire. It's a soft wire, but it's a J wire. Just removing the unplatched catheter, following with the echo images. If you can show, Wendy, maybe can show us. You have the echo in the screen, please.
He has
Echo images in the screen, just to see the guide wire position, please.
Yeah.
Okay, great.
He has a limited acoustic window that we can see that the wire is over here, being at the top of the ventricle, and we can see with multiplane imaging.
So do you think the wire is okay, in a good position?
It's okay. It's right in the top of the ventricle, in the apex.
Good.
So Fausto,
Thank you. Can you now change for the angel, please? Okay, great. Thank you. Now we remove the unplatched catheter. Dimitri, please.
Yeah. So Fausto, obviously after crossing the aortic valve with the unplatched diagnostic catheter, it's possible to insert the pre-shaped wire.
Okay, I mean the stiff wire.
Yeah, the stiff wire. But our practice is not to skip steps.
Okay.
And we like to exchange the wires and put the pigtail and measure hemodynamics and
make everything safer.
Yeah.
Great. Now we have the pigtail there. We are going to measure. We have the hemodynamics, please. May you have the hemodynamics in the screen now, please? Great, thank you. Now we are going to do the measurements with the pigtail inside of the LV, as you can see here. And you are going to see also the pressure. Okay, and now you can have above, the image above can be the room with the operators, please. Okay, great, thank you. And now, Dimitri, please.
So the gradient is about 110.
From peak to peak.
Yeah, peak to peak gradient.
So the maximum gradient is 110. Just affirm that when they showed us on the echo.
Yeah.
The mean gradient was 66 here?
88. Today was 88.
68?
88.
88 here, the mean gradient here. So the maximum?
124.
134. Wow.
And now we are ready to insert the extra stiff wire.
Okay.
This is the Confido or the Safari wire?
I think this one is the Angel one.
Okay. And now, Fausto, we can check again on echo.
Yes, with the echo imaging, please.
That we
in the screen, just in the place of the hemodynamics, the echo, please.
Let's see on echo also.
Great, thank you.
Because this patient has a small ventricle,
Yeah,
very
very small ventricle,
hypertrophic.
Yeah.
and as you could see in the AKG, I used to make a joke here with the AKG. I can see the echo images by the AKG. Do you know that?
Yeah.
Yeah. So I make a joke with the echo guys here because the AKG is very important because I'm the old fashioned. So
This
I,
is
I
really
didn't have
hypertrophic.
echo to see everything at that time. But have you see this um,
Oh,
now
wow.
Wendy is going to show us the wire position
Yeah.
in the
The
echo
wire.
that help us a lot.
It's a little low, still a little low.
Okay,
It's in the middle of the cavity,
okay,
right in
Okay,
the
could
middle.
you say again, please?
It's in the middle of the
Okay, good.
okay.
cavity, right here.
Dimitri, are you
And
satisfied with this position?
and it doesn't interfere with the mitral, right? Could you check, please?
In that position, it's kind of hard to
That's a
say.
very important point that Dimitri mentioned.
In that position, it's hard to say because
Hmm.
all the subvalvular.
Because sometimes you can get a mitral regurgitation because of the wire.
Yes.
Because if and
I'm going to see the dynamics of the mitral valve to see if we have any. He had a mild regurgitation,
okay,
and it's still mild. So I guess it's not interfering with the mitral valve, subvalvular. Uh, it
okay,
does
great.
not seem to be interfering with the mitral
Okay,
valve.
good.
Thank you. So,
Now
Fausto, we are
Alberto
ready
is
for
yes for the
pre-dilation.
pacemaker.
And we're gonna use a LV wire for pacing,
Okay,
and we're gonna pre-dilate with a 23, right?
23
23 balloon.
balloon.
We usually perform a pre-dilation when we are dealing with a bicuspid valve. And it's important
okay.
to
So in
confirm.
bicuspid valve, usually you do predilation.
Yes, yes. Some
Have you
advantages
done in
because
direct implantation?
yes, we did, but this patient has a very calcified valve
Hmm.
and with a high gradient, and it's also important to see the behavior of the balloon um, when dealing with a bicuspid aortic valve. And it's important here to confirm that the valve is already crimped. Tá tudo bem aí? Já tá. Ok.
And Dimitri, what is the current evidence supporting TAVR in bicuspid valve?
Let's
So,
try the
well, also, we have no uh, randomized data so far, but the knowledge, the evidence that we got from large registries
Hmm.
have shown that the results are very
Hmm.
encouraging, very good clinical results
Hmm.
with a low rate of PVL.
Hmm.
And there is some suggestion that the pacemaker rate are higher in bicuspid than tricuspid.
So it's time to have a randomized trial for bicuspid, only for bicuspid
Yes,
valve.
I think so.
Okay, good.
Can you try the pacemaker now? Can you start in 100?
Okay, good capture.
Yeah, I think it's okay. Turn off, please.
Okay, may you have the hemodynamics now inside of the echo?
Junto?
We just test the pacemaker. Thank you. Now we are gonna cross off the valve with the balloon.
Okay, I think that we are fine here.
What is the size of this balloon? You said
23
23.
for 40.
Okay. So Alberto is doing the procedure. Dimitri is talking. It's very important. Alberto is so concentrating. When you are doing live case, it's important. You have
Pacemaker on,
two experienced operators.
100.
Now Dimitri is coordinating the pacemaker, and he's going to inflate the balloon, and Alberto is
180,
holding.
180. Go ahead.
Oh,
Oh,
it's
Okay.
up. It's up.
Desliga o
pacer
marca-passo.
off.
Yeah.
So this is very common in
Yeah,
bicuspid,
because of
right,
the
Fausto?
horizontal.
Yeah, and because of the fact that it's a bicuspid valve,
Uh-huh.
this kind of pop up.
Uh-huh.
Yeah.
We're gonna try again.
He is recovering the pressure.
How about the recovering the blood pressure
Yeah.
and also the heart rate now is okay.
I think we can try again.
Yeah,
So we wait like 30 seconds just to recover and
yeah.
everything.
Okay.
So you try to push a little bit the balloon while you're inflating.
Yeah.
Yeah.
Alberto is holding.
Pacemaker on. 100.
Yeah. Okay.
180. Sini.
Okay. Great. Great. Yes.
Okay, that's it.
Good.
And pacemaker
Yeah.
off.
Okay. Predilation is okay.
Okay.
Now let's show the echo image, please. The patient is okay. The blood pressure is recovering. Wendy.
Right here, well, it seems to like
First, what do you look for?
it's like
So,
yeah.
aortic regurgitation.
Yeah, this
Yes.
is the moment in which we have to see if there's not an aortic regurgitation, not vinculated with the catheter, with the PG,
Compressa
because
no
it's
chão.
always going to be something coming back to the ventricle through the dispositive.
Okay.
Mhm.
Uh,
Okay, the predilator is
it
okay.
seems to be okay. It seems to be okay. It's not more than mild.
So, Dimitri, the size for a bicuspid valve is different for a tricuspid?
Yes, we tend to be based on annular area,
Mhm.
like we do for tricuspid, but it's also important to measure the intercommissural distance
Mhm.
and try to use the circle method as we showed
Uh-huh.
previously. And for this patient, we selected 26.
Because
So
of the simulation you did.
yeah,
Okay.
with the Trementia
So,
software.
is there a difference between balloon expandable and self-expandable?
In terms of
The bicuspid?
bicuspid, I think that when we are using a self-expandable device, these devices are more forgiving. You can sometimes choose a bigger valve when you
Mm.
are dealing with a self-expandable valve. But with balloon expandable, we try to be precise in terms of sizing.
Okay. Alberto, you choose a my valve, balloon expandable valve. Could you please tell us which specific features of this kind of valve could be highlighted?
Yes, of course, Dr. Fausto. So it is a balloon expandable valve that has this intermediate size, as we shown.
Could you please bring the camera to the valve here now, to the hands? Okay, great. Thank you.
That has the intermediate
Can you give
size.
some zoom here? Okay, Alberto, go ahead, please. Sorry.
So we have a bovine pericardium with an calcification treatment called
Mhm.
Antica. We have a PET puffing sternum to minimize the incidence of PVL. And what is important to highlight is the fact that the valve is crimped directly in the balloon.
Mhm.
So we can retrieve the valve in case of inability to cross the annulus or another structure. For me, it's a good feature
Uh-huh.
that we have in my valve. So the delivery system, we have one single step, that
Mhm.
is the deflection wheel.
Mhm.
We have to turn clockwise to give the deflection. Usually half of the deflection is enough to cross the most of the anatomies.
And could you briefly tell us how is our experience with the my valve here at Dante?
Of course, Dr. Fausto, we have the biggest experience in South America, in Brazil. We have more than 150 cases already performed. We started in December 2020. You guys performed the first case. We have good clinical results. We have low pacemaker rates with one single digit, low PVL, and a good hemodynamics.
How about the long-term follow-up of this? I mean, we have done for almost 2 years now. 2 years now.
Yeah, we already have the midterm follow-up with a good results. The patients are all of them less than class 2 of dyspnea. And the gradient and the aortic valve area is maintained during this period.
Okay, good to
So
know that.
let's check the valve
Now
orientation
let's
here.
go the procedure. Let's go to the procedure.
It's also important to check the valve orientation. We have the external PET puffin here, directed in the distal part, and the open cells region in the proximal part. So it's
Can you zoom this, please? Thank you.
so it's aortic position. I think we can move on.
Okay. We already checked the volume on the deflator
Oh,
also.
thank you. So
How hard is when you go to get across the introducer with the valve?
it is an expandable sheath, so we have to make some effort to expandle it, but it usually is not too hard to.
Yeah.
You can see it's not hard to push the valve.
Okay. Great demonstration how you can advance the valve through the introducer sheath. It's
So
perfect.
I'm going to do the deflection here.
Could you bring the camera here to the Dimitri hands, please? Right here. Just a little bit proximal. Okay.
So Fausto, the delivery system is very flexible,
Okay.
but on the other hand,
Uh-huh.
as compared to other balloon expandable valve,
Uh-huh.
has less pushability.
Okay. It's important to know. Now you can across the valve. It's a very calcified. The calcium was more than 3,000.
Doing more flexion.
Yes.
No.
Can you?
Let's try again
Yeah.
with less deflection.
Less deflection. I think to pull a little bit the wire. Yeah, that's it. Yeah.
Okay.
Okay. You got now. That's
Let me change
a
the
very good
projection
feeling
here.
when you can across the valve. Now you're going to that view. It's a 26 LAO and
LAO.
7 Caldo that Tomo gave to us.
A bomba tá pronta?
Let's do some injection here.
Yeah,
just
let's
to...
perform the first angel to confirm the position. Injeta.
It's a good position, right?
Yeah, I think so.
What do you think so?
A little bit higher. Should we?
Oh, I think it's okay.
So let's go.
Tem relógio aqui, não?
So we are ready to implant the valve. So pacemaker on.
Deixa a bomba pronta.
120.
Deixa a bomba pronta, tá, por favor?
Okay, 180.
Okay.
Finish.
Injeta. Let's see.
Okay.
Go. 1, 2, 3, 4, 5.
Pacemaker.
Pacemaker off, please. Let's relieve.
Hemodynamics, please.
Perfect.
Okay.
Let's take a, okay. Great, it's recovering.
Can you pass me the
Do
wire?
you need to give some fluids, Dimitri?
Yeah, it seems to be a small
Give some
paravalvular
fluid.
leak.
Okay. May you have the echo in the screen, please? Thank you.
So let me show you.
So Wendy?
Yeah, it seems to be a very mild paravalvular leak related to the interventricular septum. I'm gonna try another
Thank you.
view
Vamos preparar a bomba aqui de novo, gente?
just to check.
He's recovering.
Metal líquido.
He's recovering.
Hmm?
He's
Metal
recovering.
líquido.
Vai pra frente.
Yeah, it seems to be there, but it's mild.
Tira.
Mild paravalvular.
Volume. Mais volume pra ele.
So do you think the echo images are okay, Wendy?
Yeah, it seems
So
to be
no
okay.
pericardial effusion,
No pericardial effusion, no
no
contractility
regurgitation.
alteration. And something important, not increase
Dynamics
of
are good.
the gradient through the ventricle.
Okay, can you see the
Seems,
gradient?
well, let's just wait a little bit. The patient's coughing, but it's right here.
Okay. So while we are trying to calculate the gradient, please, could you
Yeah.
go back with the hemodynamics image, please, just to show the blood pressure is recovered. So this patient has a severe left ventricle hypertrophy. And when you open the valve, sometimes you takes time to to get better and the heart can recover.
Yeah.
At this point, uh, the blood pressure is over 100, the systolic blood pressure,
So we're gonna measure the
the,
hemodynamics
the
after valve
hemodynamics now.
implantation also,
Well,
Professor.
Dimitri is taking the pigtails, and while Wendy can tell us the echo
the
measurements.
prospheric gradient, it's 4, 2,
4,
4.
the maximal gradient,
The maximum,
max.
4,
So the median is 2.
2.
Okay, great. So can you show the echo images now, please?
Yeah,
Wendy, can you show
yeah. Here the
the audience,
flux,
please?
right here, we can see the flux going through the valve, the prosthetic valve, and the gradient right here, 4, 2, with a peak max velocity of 1 meter per
Okay,
second.
good,
Really good.
great, very interesting.
Yeah, no pericardial effusion or ventricular dysfunction at all, and not increase of the intraventricular gradient.
So Fausto,
Yes.
in bicuspid,
Can you bring the camera to the operators now, please?
we tend to implant the valve a little bit higher
Uh-huh.
because uh, the bicuspid has a different configuration.
I could see that. It's very
It's like
important you explain people
in
this.
terms
Yeah.
of a leaflet coaptation, it's like a volcano.
Hmm.
And we tend to implant the valve a little bit higher,
Uh-huh.
also to prevent conduction disturbance, because as we previously said,
How about
there's a risk, increases risk of pacemaker need in this
Okay.
patient with very calcified
So in
bicuspid
this
valve.
situation, Dimitri, how about if you have a low left coronary takeoff?
You have to balance the
Uh-huh.
risk of coronary occlusion,
Uh-huh.
and it's also important to measure the sinotubular junction also,
Uh-huh.
not for to prevent complications during the procedure, but when you think about durability and the possibility that this patient is gonna need a second TAVI in the future,
Okay.
so we are very careful about valve positioning, type of valve in patients, for
So
example,
in
with less
this
than 80
specific
years.
case, you can see the valve is pretty close to the coronary takeoff.
Yeah, but
So I saw when Alberto was implant the valve, he asked for to do injection.
mhm.
Is that not common? You do all the times to do injection during the inflation of the
Yes,
balloon?
we tend to do all cases like that, just
Oh, like
to,
that, but not
yeah,
in all cases.
no, we usually do an angel
Uh-huh.
during implantation,
Uh-huh.
just to get precise positioning. Uh,
Can you play the
yeah.
just to show the people how it was that? How do you choose in this view? Roberto was pushing the valve while we were inflating.
Yeah, Fausto, I can show you. The
Uh-huh.
valve has a pattern, as you can see in the fluoro. You have a first dense band, one light band, and a second dense band.
Mhm.
Usually, we use the second dense band to position where we have to reach. Usually, we are using the base of the pigtail. In this particular scenario, we use the base of the cusp to position in this place.
So we use the base of the cuspid.
Yeah.
Okay.
and this is during inflation.
So yes. And can you tell us, Alberto?
Yeah, during the inflation, if you perform an angel, you have a chance to replace the valve like millimeters or
Yeah,
something
to the
to place
position.
in the best position we can reach.
Were you worried about the high implantation that you had to miss the valve or not
In,
in this
in
situation?
the bicuspid scenario, we showed you that the calcification are in the top of the cusp.
Mhm.
So usually the anchoring point is at that point, usually at 4 millimeters up in the annulus.
Mhm.
So that were our goal to place the valve.
So
Okay.
Fausto, maybe Alberto can show to you the hemodynamics.
Okay. Alberto, please.
Yeah, as you can see there, we have no gradient, peak gradient, or only one gradient from
Mhm.
the left ventricle to the aorta.
Uh-huh.
I think it's a really good result,
Yeah.
compatible with the echo. I think we can move on, take the
So
pigtail.
no gradients, right?
Uh,
And diastolic pressure, it's
compress.
around 50, and we can see a dichrotic notch
Uh-huh.
also. So we think that we got a very good hemodynamics
Yeah.
result.
Okay, good.
Let's see the angel.
Uh,
Let's take off the
okay.
pigtail
Are you
and
gonna do
feel it.
angel?
Yeah?
Because the patient has normal renal function, you're just not gonna check. But you don't need if you want.
No, we don't
Okay?
need it.
Because do you trust what Wendy showed us
Yes,
in the echo?
sure.
Okay, good.
Thank you.
Good reputation.
On fluoro, the valve looks well expanded.
Mhm.
We're gonna take out this pigtail here.
Okay, and after you do that, I'm gonna ask you Wendy to show the final images from echo, and maybe you can take care of the access, and
Okay.
I'll move to the next room.
Okay.
Vamos preparar a bomba
Não?
2020, por favor?
Wendy,
Wendy,
Pronto,
quer
né?
tirar o eco agora?
Tá pronto, né?
I think it's okay. Injeta.
Great. So what are your comments now, Alberto?
So we have no PVL, as we shown. We have no gradient. In my opinion, it's a really good result. I think we can move on and finish the procedure.
So how can you access the coronary artery, the left coronary artery in this?
So
Have you done some cases? I can see some calcified arteries up there in the left anterior descending.
Yeah.
So if you need some procedure in the coronary, it's going to be easy.
yeah, you can see that the valve has a bigger diamond.
Yes.
There. So usually we use this place.
Have you done that in some?
Yeah, we have done.
Uh-huh.
These are
Trying to-
open cells.
Yes, I could see that the open cell. But have you done that in a patient that you placed a TAVI and
Yeah.
some years or months later
Okay.
you need to do a coronary intervention
Yeah.
in this valve?
In this valve specifically, no. But after the implantation,
Uh-huh.
we did sometimes the catheterization of the left man.
It's going to be
or-
easy.
It's easier with a balloon expandable valve.
Okay.
With a small profile,
Okay.
and the next generation of balloon expandable valves will be possible also to perform commissural alignment, just to make it easier to cannulate the coronaries in the future.
So can you expand it to young patients right now in bicuspid valve, Dimitri? No?
You have to be very careful when selecting those patients and
okay.
look for the anatomy, look for the type of bicuspid, the degree of
great.
calcification. But yes, it's possible.
So let's have now the echo image in the big screen, and Wendy's going to show us the final images, please.
Yeah.
Wendy, please, may you have the echo images? Okay, great.
Right here we can see the flux through the valve.
So what do you look for, just for the audience to see, what do you look for at this time? The procedure is just fine. We finish with low gradient, no aortic regurgitation by angel. What the echo can help us right now,
Well,
Wendy, please.
we must make a complete exam, not only see the prosthetic valve, we have also we have to see the mitral valve to see if that Actually, nothing happened when they liberated the valve, and we can see that the ventricular function is perfect the way it was
Uh-huh.
before the procedure. There is no any segmental contractility alteration. There is no pericardial effusion, and we can also see the results in the hemodynamics, the way we showed you, the minimum gradient, and there is no exacerbation of the ventricular gradient looking for some suicide ventricle or something like that. So
Okay.
it has to be complete, not only to see the valve, but to see the whole
Okay.
conjunct.
Great. So are you quite satisfied with this kind of results?
If I'm
Satisfied?
satisfied,
Are you okay?
totally. We see this every
Are you
day, and
happy?
totally happy.
Okay,
Because
good. Good. So Dimitri, final
Fantastic.
words. What should we?
We're gonna take care of the access here.
Uh-huh.
As
Have you done the only one
yeah, only one
progride?
perclose.
Uh-huh.
I
Can you
think
show?
it's
Can
not
you bring the
bleeding.
camera to the Alberto hands, please? And you can finish here and
Yeah.
just show. So
Apertar mais um pouco.
I was going to the next room, but maybe you are finished now. I'm gonna just take a look. Can you just take a look when you finish this?
Yeah. Yeah.
So, if you remember, we have a 5.2 in the femoral artery diameter. Is that correct, Dimitri?
Yes.
You know, Alberto?
Yeah,
So we are a
5.2.
little bit lower from the minimal.
Yeah, we're pushing a little bit the
Yeah,
limits.
you pushed that. So, but you did so careful. How can you? What can you do to avoid a vascular complication in a patient like this, Alberto?
Usually the analysis, you have to see if we have calcifications. Usually the 360 or 270 calcifications usually goes worse than the
Okay, can you have
patient.
a picture in picture from Alberto and also his hand? Is that possible? Just to check with both cameras. Thank you.
So
Okay, good. Go ahead.
when we have no calcifications, in my opinion, the access goes better than we have calcifications. In this particular scenario, we have no calcifications in the stenosis
Uh-huh.
point, the 5.2. So we performed a contralateral protection. If we have an accident, we are able to go with a balloon, inflate the balloon until we.
What do you have from the contralateral?
Sorry.
What do you have in terms of catheters and guide wires?
Yeah, we have a point 18 wire.
Uh-huh.
Then we can use to go with the balloon.
Uh-huh.
And then if
If
you needed recovered or
Where
stent.
is the 18 wires?
it's here.
Okay, it's right here.
Yeah.
Just beside of the puncture. If you look at here in the hands, okay, you have the 18 wire here.
Yeah.
Okay, so if you have a complication, what do you do with this?
We go with a balloon, like a 5 to 40 balloon. We
Uh-huh.
inflate the balloon until we think or
To decide.
we have a cover stent or surgery.
So if you
Something like
go
that.
with a cover stand, you do to the contralateral
Yeah, we go to the contralateral.
to finish this. So can you bring the slides back just to show the access again? I think it's important for the audience. There is a rotation. I mean, different people. Can you bring the slides back? May you have the slides
Reverter parina.
back? Ask them just to put the slides, please.
Pede pro Radel
Okay.
reverter parina. Reverter
One before
parina.
this, before. Okay, stop. So, Dimitri, can you make comments about this image? I think it's very important with what you have there in the Alberto hands now doing the compression.
Yes, like we said before, it's a challenge anatomy because of small diameters, but we think that we perform all the preventable steps with ultrasound guided puncture, and we use a expandable sheet,
Uh-huh.
and we protect the vessel. And after we gave some pretamine, we're gonna perform at the end final angiography just to look for any problems.
Okay.
But
And when this patient's gonna walk?
in 4 hours,
In 4 hours.
yeah, our minimalist approach. We have a protocol here. we're gonna send this patient to our recovery room
Uh-huh.
here at the cat lab, and
Okay.
he will be observed for 4 hours, and then he will be able
To walk
to walk and
and
to
discharge tomorrow.
maybe tomorrow.
Tomorrow. So can you show now with the big camera now? Can the slides out now and with the camera on the room? Okay. Can you show the Alberto's a puncture, please? Okay.
So
It's great.
we
So it's
have,
still bleeding? No.
yeah, just a little bit
Okay.
from
All right.
I think it's from the skin. But
Okay.
I
All right.
usually like to compress like 3 to 4 minutes,
Okay.
and then we can perform a control angel.
So
The patient maintain his body pressure
okay.
after we took off the sheath.
The procedure is gone.
I think the
Finished.
procedure is
So
done.
so it's now 45 minutes since we started. Congratulations to you. Can you have the cameras here to the operators, please? And Michelle, you can be close to them. Please, you did an outstanding job here in a bicuspid valve and horizontal aorta with a low-risk patient for surgery. And you did a great procedure.
Thank
And
you,
with
Fausto.
a great images from the echo. If you can just turn this camera here to the Wendy and all the team from echo, anesthesiology, and technicians. So thank you.
Thanks for the
Thank you.
opportunity.
So I'll meet you in the next lab now to have to show you a coronary case that's going to be very interesting. Ricardo Costa and the team is there.
Okay.
See you guys.
Hope
Bye.
to see you next week. Bye bye.
Bye.